Hello, everyone. This is Aliyah from the Asia eHealth Information Network. Welcome to our special AHIN Hour, which is part of our bi-monthly webinar series where we feature topics on eHealth on a special schedule. This webinar is attended by 25 countries in South and Southeast Asia, mostly members of the AHIN. If you're not yet a member of the network, it's okay, and we'd love that you join us at www.ahin.org. AHIN's Secretariat is at the National Telehealth Center in the University of the Philippines and is supported largely by the World Health Organization and partners. Our topic for today is on innovation in primary care, insights from the Primary Care Innovators Handbook. This webinar will give us an overview of the Primary Care Learning Collaborative, where primary care leaders identified key challenges linked to scale, sustainability, and providing quality care, which are among the many issues most healthcare organizations face. Tonight, let's join representatives from R4D and primary care leaders in this interactive webinar discussion, Insights from the Primary Care Innovators Handbook. But before we start the session, there are four things I would like to give you an instruction for this webinar. Our platform, our ways to participate, our program details, and our email feedback. But before I start the orientation session, I would like to know via chat what countries are in our meeting room. Could you go to your chat box located at the right panel of your screen, and can you chat the country where you are coming from, just for us to know the demographics of this meeting room? Can I have a chat from our friends from Dr. Sheila John Luxay, Rhea Batley Boy, Richard Yoder, Rushba Malde, Alejandra Maria Carissa, Donica, Lane Goodman, Emily, Dr. Jakir Sanjeev, Rajiv, Dina, Alex, Chatilya, Gilbert, Jamshaid, Jeremy, Anu, Rajiv, Rajan. Thank you very much for all the chats you have sent. I now know that our participants are coming from Bangladesh, from Indonesia, but studying in Taiwan, from Dina, from the Philippines, from South Korea, from Kenya, from India, from Nigeria. Thank you so much for all the responses we have received so far. Please maintain using the chat box and not the Q&A box. Anyway, I'll walk you through on using our platform for this evening. First off, I would like to remind you that we're now using Cisco WebEx Meeting Center. Our link is bit.ly.com/AHINHour. Our room number is 865-884-737, and our password is TISI123. If you have trouble hearing my voice, or if you can't connect correctly, you can log out this session and rejoin immediately. Your mic will be mute for the rest of the meeting, but you can actively participate by sending your feedback, chatting your response, and posting your questions, and also answering our poll. You can send your feedback to the session by saying a yes or a no, a too fast or a too slow, an applause, and a virtual laughter via the dialogue icon with a check mark on the lower right panel of your screen if you are on Windows. Can we try using the feedback button now? So can you answer this question, are you feeling well today? You can signify a check for yes and an X mark for a no. Thanks, Devashish, for your response. How about the others? How about for Dr. Sheila Luxay? Were you able to locate the feedback button? Prabin, thank you for the check mark that you have just sent. For the others, Gilbert, Shatila, we're just trying this one because we will be maximizing this for the rest of the session. How about Rhea? Thanks for another check mark from the Ateneo Innovation Center. How about for the others? Donica, Emily, Martha, Dr. Jakir. Thank you from the Mary Stopes International for a check mark that you have just sent. How about Gilbert Mina, Jeremy, Sanjeev Minoka, Dr. Sheila John. Thanks, Richard Yoder, for all the responses. Thank you also for the chat that we have receiving. Okay, very nice. We now go on to our next option, and that is chat chatting. You can type your message to the speaker or to the panelist or both in the meeting room. I strongly encourage everyone to chat your thoughts inside our meeting this evening. But there's a warning that you cannot chat to all of us because this is the default feature of Cisco WebEx. Meeting center to bring order within the chat room. The panelist or the speaker are the only individuals in the meeting room who can chat to all attendees. You can also post your questions by selecting the Q&A box icon, and this is at the bottom right of your screen. In this meeting, all questions should be addressed to the host, and as host, I will consolidate the questions and ask this to the speaker. If you have further clarifications, you can raise your hand using the Raise Your Hand option. You can also ask our speaker directly via voice, and just raise your hand, chat me for a signal, and I can unmute you on that part. Just be sure you have a mic with you turned on and you don't have any other background noise. And for our last feature, you can answer the poll which will appear in the right panel of your screen. And on the moderator signal, the poll will be open and you'll have to key in your answer. Results of the poll will be released right after. Now, I think we're done on how to participate. Let's go to our program details. This session will run for 45 minutes to 1 hour, and you can send your questions to the Q&A box as it arises from your head. And lastly, please check your emails as I will be sending you an email feedback form. And I would like also to inform you that this session will be recorded and all information will be shared to a larger audience of the Asia eHealth Information Network. So I hope that we were now able to use the functionalities of our meeting room now. I would like now to direct you to our polling option. Um, a while ago, I was asked by Tricia, one of our speakers, to give a poll to you, and we'll be delivering that, and I hope that you would be actively participating on that note. So that's the 4 things we have to remember: our Cisco WebEx Meeting Center, our program details, our ways to participate, and our email feedback. I would like to say that we're so privileged to have a great team leading our special AHIN hour tonight, and with 3 speakers from the Primary Care Collaborative. Our first speaker is Tricia Bohlander, and as a global health consultant, Tricia advises Fortune 500 companies, governments, multilateralists, major foundations, nonprofits, and impact investors around strategy and impact. She has worked in India, the Philippines, Australia, Thailand, Rwanda, Ghana, Nigeria, and Ethiopia. She received her BA from Harvard University, MBA from Columbia Business School, and MA in International Affairs from Columbia University. Her current focus is on behavioral change, leadership, and organizational effectiveness. Our second speaker is Dr. Devashish, who is a family physician and social entrepreneur. He completed his MBBS from the All India Institute of Medical Sciences, New Delhi. After pursuing higher studies in health informatics in the US, he returned to India in 2008 and has been founding and leading startups in the healthcare field since then. In Swash, India, he helped design and implement financially sustainable health systems for the poor. He co-founded Prima Clinics with the idea of making quality primary care affordable for middle-income Indians. In 2011, he founded Ross Clinics to rejuvenate the tradition of the family doctor, providing trustworthy quality care for day-to-day illness and health needs of urban Indian families. And our third speaker, Stephanie Coxula, is the co-founder of Penda Health, startup providing high-quality, affordable outpatient healthcare through a chain of clinics in Kenya. Penda Health launched its first clinic in February 2012 and since then has had over 3,000 patient visits with an average spend of $5 to $6. By 2020, Penda will operate over 100 clinics across Kenya with millions of patients. We'll have a powercast of speakers tonight. And again, this is Aliyah, your moderator, now turning over to our first speaker, Tricia Bohlander. Tricia, I'm now passing the presenter controls to you.
Great.
Hi, Tricia.
Hi there, and hello everyone, and welcome to the Innovation in Primary Care webinar. Let me just get our slides up. My name is Tricia Bohlander. As Leah had mentioned, I am a global health and leadership consultant. I'm here representing the Center for Health Market Innovations, and really thrilled to be joined by my colleague at Results for Development, Lane Goodman, who's on the line as well. And very thrilled to be joined by our partners and our collaborative members, Stephanie Casella, who's the co-founder of Penda Health, and Dr. Devashish, who is a founder at Ross Clinic. Our objective today is to share with you the insights and learnings from the Primary Care Innovators Handbook, which we just launched earlier this year in February. And if you haven't already downloaded it, I strongly encourage you to do so. And the easiest way to do that is actually through the Center for Health Market Innovations website, which is healthmarketinnovations.org. If you scroll down on that website, you'll see featured content on the bottom and then a link to the Primary Care Innovators Handbook. We'll also have a link to it later on in the presentation, but wanted to give you all an opportunity to download it as well. So this is our agenda for the next hour. I'll start off for about 10 to 15 minutes to give an overview of the Primary Care Learning Collaborative and really the development of this handbook, which in many ways is a culmination of our year working together as a collaborative. And then we'll spend the majority of time really hearing from our members themselves. So Steph Casella will talk about the experiences that Penda Health has had as a member of the collaborative, and then Dr. Devashish will talk about the experiences of Ross. And we'll leave about 15 minutes for question and answer at the end, and also pause between the two members' updates to provide you all with an opportunity to ask questions as well. So before we begin, I'd just like to point everyone to an informal poll, which I believe that Aaliyah has set up. Would just really be curious to hear how many of the participants of this webinar are primary care providers or practitioners yourselves, either within, here it is. Thank you, Aaliyah, for pulling this up. So if everyone can just take maybe just 30 seconds to answer this poll, it would really help us to just better customize the next 45 minutes or so. Great, and as those polls are being consolidated, I'll move forward and we'll circle back to that. Great, so let's get started. So some of you may already be familiar with Results for Development. R4D is a nonprofit organization based in Washington, D.C. that focuses on accelerating social and economic progress in low and middle income countries. One of its main initiatives is the Center for Health Market Innovations, which really is just an incredible resource. For those of you who aren't already familiar with CHMI, it's a digital platform that catalogs over 1,400 now, I think we have, global health programs around the world. And so you can log on and learn more about each program. And it's also just a really great resource for practitioners and those in the global health field to learn more about one another's work. So once again, that website, if you're interested, is healthmarketinnovations.org. And so through analysis of the CHMI database, it became clear that there were certain common challenges that primary care organizations were facing really globally. And these were related to quality, to sustainability, to efficiency, to scale. And this is important because franchises and chains have really proven to be promising models to lower costs, increase quality, and to remove barriers to access. And so the opportunity that we saw was really in developing a learning collaborative. So specifically one focused on peer learning, which would facilitate knowledge sharing and joint problem solving around common challenges. And so about a year and a half ago, we launched the CHMI Primary Care Learning Collaborative. The goal of this collaborative has been to use a peer learning approach to really tackle the big challenges that primary care organizations face. So these are challenges around scale, around sustainability, around quality of care, themes that likely resonate with many of you on this webinar. We worked with 5 organizations profiled here. So LifeNet International from Burundi, Penda and Access Afia from Kenya, and Ross and Swap from India. And again, we're very lucky tonight to have Stephanie from Penda and Devashish from Ross with us today. As you can see from the countries represented here, they're all different geographies, but really all joined by a market-based approach to primary care. So an approach that's really focused on delivering high-quality care to low-income patients. Again, I'm sure many participants on this webinar resonate with that effort. So we spent a year learning and working with one another through this peer collaborative. We did this a number of ways. So one was through 2 face-to-face meetings. We launched this in Delhi, and we had a mid-year meeting in Nairobi. And then we also did this through monthly calls, really with the purposes of facilitating knowledge sharing between primary care organizations. Like Aaliyah and the network here, really leveraging technology, we tried to do the same. And so through these calls, we experimented with a number of different ways. So traditional Skype, but then also through Google Hangouts, where we were able to actually use video to really connect and hear from one another. The mantra that we've really been using over the course of this year has been all teach, all learn. You know, these meetings have really been an effort to share knowledge across all organizations and to really problem solve around common challenges. And so the first part of the collaborative, the first 6 months or so, really focused on individual members' challenges. And so whether that was a challenge and a goal to grow and expand, or to improve quality of care, or to increase patient footfall. And then the second half of that collaborative was really focused on consolidating a lot of these learnings and sharing internally and starting to package that. Really with the question around what can we as a small collaborative made up of 5 organizations really share with the wider field at large. And this handbook really is the culmination of this effort. I'm really excited to share that earlier this year in February, we launched the Primary Care Innovators Handbook, which again you can download directly from the CHMI website. But rather than seeing this as an end product, we really see this handbook as just the beginning, really of a conversation between leaders and between implementers around tools and approaches, and really talking about not only successes, but failures as well. And so that's why we're really excited about webinars like this, where we can not only share learnings of this handbook with practitioners like yourselves, but hopefully also hear from you all about what parts of this handbook really resonate, and what are your own learnings and reactions in response to hearing about what some of our members are doing on the ground. So in terms of the actual organization of the handbook, we divided the handbook into 3 sections, which really encompass the 10 areas that our members identified as the greatest challenges that they face. So you'll see this is divided around initial setup and expansion of clinics. Secondly is around providing care, and more specifically, how do you provide high quality care given the resource constraints that many of these organizations face. And then lastly is around building systems and really the question of scale. So I wanted to take just a minute and pause here and ask a poll to the attendees of this webinar, which is this. Out of these 10 bullet-pointed questions, which of these challenges do you see as your biggest challenge that you face in your own organization?
Thanks, Tricia. But before we start the poll, I think we are already showing the results of the previous poll.
Great.
Have you seen that? We have the bar graph shows that most of our members here are from our primary care providers.
That's wonderful. That's wonderful. And so we definitely want to hear from all of you, particularly in response to some of the ideas that you'll be hearing about from Penda and Ross. And hopefully we could get a global conversation going around really what's been working and what are some insights and learnings that you all can share with each other as well. Wonderful. Thanks, Aaliyah. And now you should all be seeing the second poll, which is really listing out these 10 topic areas that the handbook focuses on. And if everyone here can just choose, which of these do you consider as the key challenge in your organization? And as you all do that, I'll continue with the rest of the slides for the purposes of time, but we will return to this poll before passing it on to Steph and Devashish, and hopefully based on the particular challenges that you all have identified, we'll be sure to try to address some of those through the learnings of this collaborative in the handbook. So there are a few unique elements of this handbook that I wanted to call out to all of you today. So first is that these chapters are written in the voices of the primary care implementers themselves. So this is something that was really important to us. So note these aren't case studies written by outsiders in the third person. This truly is a handbook based on voices from leaders in the field. And I think that's really important because when you look at the landscape now, there isn't a lot of that, frankly. And so I think that that's what this handbook hopefully provides to the larger global health networking community. And then secondly are the voices of commenters throughout the handbook. And I know that this wording is really small on the slides themselves. I promise they're more user-friendly when you actually download the handbook. But what I did want to call out here are these gray call boxes that you'll see to the left and to the right of the actual content. And these gray call boxes are comments from other primary care organizations. So that includes members of the collaborative themselves, but then also external primary care organizations as well. So as you'll see here, this chapter has been written by LifeNet International, and the comments around include some from members. So there's one from Ross and Access Afia, but then you'll also see some other primary care organizations external to the network. And the objective here again has really been to expand the dialogue, and so to understand beyond these 5 members kind of which of these ideas resonates with other practitioners in the field, and what works, and frankly, what doesn't work or hasn't worked in other settings. And so this slide gives you an overview of the 8 commenters of the handbook, and you'll see it's really global and around the world. And again, the objective of having these commenters is really expanding the dialogue and seeing what works and what doesn't really globally. And so I wanted to say just a few words on what this handbook is and what this handbook isn't. So we're really excited that this is one of the few tools that we've seen told in the voices of implementers themselves. And so with that, these really are reflections around what's worked for specific organizations with the intention of arming the reader with concrete ideas to test. And so you'll see at the end of each section, just like you'll see here on the on the side is a section on ideas to test for each organization itself. So clearly this isn't meant to be the last word on these challenges or a prescriptive how-to guide, but really the beginnings of a larger conversation in this space. And then finally, I wanted to share a few learnings from the last year and a half of this collaborative. And so when I reflect on the learnings from the collaborative, I really think about it in two ways. And one is the collaborative approach itself around what worked and what hasn't worked. And then second is the content, really the content areas that we've explored over the last year and what has really excited members and generated the most interest and dialogue from the members in our collaborative. And so in terms of the collaborative model itself, one thing that we found is really the need to be open and flexible based on the members' needs. And so as an example of this, we went into the collaborative thinking that we would focus on a specific aim or goal. So sort of like having a gym buddy, the collaborative members would have other organizations to sort of work with and work towards particular aims and goals. Well, what we found, and Steph and Devashish could shed more light on this, is that what seemed to resonate much more was rather than focus on a particular aim, was to really use the collaborative model as an idea sharing and idea generation platform. And you'll hear from Steph and Devashish some of the ideas that they've gotten from other members of the collaborative. We've also learned that in-person meetings are crucial to developing trust and relationships. So often this doesn't even happen necessarily in the meeting room themselves, but could happen on the bus ride or on dinners. And through that in-person trust that was generated, that really carried the collaborative through all of the virtual sessions. And then lastly, we found that it worked to have similar primary care models, but spread across different geographies. Particularly when we had site visits in each of the countries, we found that this enabled members to have new eyes to old problems because they were similar problems and challenges, but then they were seeing how this worked in different geographies. The content I won't spend too much time on because I think that's what Stephanie and Devashish will do, but just to point out that the areas that really kind of seem to spark the most interest over the last year and a half, one has been around patient-centered innovation, and Steph and Penda has really kind of led the charge and the way within our members around a focus on patient-centered care. And we actually had a blog published within the Lancet Global Health around the time is now for patient-centered innovation. Secondly, our primary care services that were offered. There was a lot of discussion on this and a lot of sharings and learnings around what each of our members were offering in terms of services, and then concurrently how that played in with pricing. 4 of our 5 members are for-profits, though they all are market-based. And so pricing really becomes crucial in terms of thinking about this sustainably and profitably. And then thirdly, and related to that, is really marketing and increasing patient footfall, particularly as the organization seeks to expand and grow. And so those are really kind of the key nuggets of insights and learnings. And with that, I will turn it over to Steph Pizzella to talk about Penda Health and their experiences and learnings with the collaborative.
Tricia, can you hear me okay? I think my microphone is now on.
Yes, very well.
We can hear you.
Wonderful. Well, thank you for that overview. It was fun to travel down a bit of memory lane and remember all of the exciting work that we've done together over the last year. So thanks for that overview. It's very nice to kind of reflect. So as Tricia said, I was one of the lucky participants of this collaborative over the last year. As Aaliyah mentioned, my name is Stephanie, and I am the co-founder of Penda Health. Penda Health runs a chain of medical centers here in Nairobi, Kenya. We opened our first medical center in 2012, And we now actually are operating 3 medical centers around Nairobi. Over the past 3 years, we've treated actually 35,000 patients, and we aim to open between 6 and 8 clinics over the next 3 years, and expand those numbers to be seeing about 250,000 per year. Penda Health really focuses on providing a comprehensive primary care experience for the entire family. So we see members from, we see men, women, children. We see a huge diversity of patients, everybody from people who are having complex hypertension issues to people who are having the common diarrheal diseases, malaria, maybe just a basic headache, or needing counseling on a particular psychiatric issue going on in their life. So we see a huge diversity of patients. We generally target the low and middle income families in Kenya. So these are families who can't afford the more expensive private care. And these are people who are not necessarily wanting to attend the free government facilities. There's somebody who's got a little bit of an income and is therefore looking for a faster and more efficient healthcare experience. I want to just mention a couple things just to give you a bit of a picture of Penda. I want to talk a little bit about what our services are and about also how people pay for our services. I think that's very important. And then I'm going to move on to kind of what I think of as Penda's most important thing, which is the style that we provide our care through. So you guys, many of you are primary care providers. So let me just give a quick listing of what our services are. So we have a full and comprehensive lab, everything up to hematology. We have a full drug store within our clinics. We have over 250 different drugs that we keep on in our facility, and patients are dispense those medications. We provide full dental services, everything from a tooth checkup to root canal. We do ultrasounds. We have specialist clinics of gynecology and pediatrics. And then we do family planning, prenatal care, immunizations, and chronic disease management. So that's sort of what our services are. 90% of our patients pay with cash, and they pay between $5 and $6. We do have 5% of our patients who pay with an insurance model, and these are the micro insurance partners, not necessarily the more corporate insurances. And in Kenya in general, 5% of the Kenyan population has insurance. So our clinics are actually seeing basically a representation of the Kenyan population within our clinics. Some people who have insurance and then many who don't. Our most innovative form of payment is that we have a relationship with a number of corporate partners. These are factories in the towns that we work in, or schools, or even churches. And we go to them, and their participants, the people who are employed by these organizations, these corporate partners, are able to come to our clinics, and they get health care without having to pay that day. And we bill the company at the end of the month, and they deduct the payment for their health care from that person's salary. This has allowed us to open up our services to patients who are not able to access health insurance, and it also smooths the patient flow throughout the month. Because Kenya is a cash-based economy, it means that if you don't do that, you end up with very big spikes of patients at the end of the month and the beginning of the month, and in the middle of the month, there's very low volumes. So we introduced this post-paid relationship in order to smooth our numbers throughout the course of the month. I hope that gives you a bit of a picture of sort of who Penda is and what we do. I want to just comment on what makes Penda very unique, I think, in the primary care sector. Penda is really trying to be the friendliest healthcare provider in Kenya. And what that means is that we go out of our way to make sure that our patients have a world-class experience. We do 3 main things to achieve that. Every patient who comes to Penda who's a child gets a balloon. They get a pink or a blue balloon, and that makes the patients delighted in the waiting room. Even if they have to wait a little bit long, they're very happy. We make sure our washrooms are always clean. And every single patient who comes to Penda, no matter what they came for, gets a follow-up call 3 days later, and we just ask them how they're doing. That allows them to give us feedback on the quality of the care that they received, their experience, and we also are able to pick up patients who are not getting better. When we talk about patient experience and we talk about providing that world-class experience, what we've identified is that the vast majority of a high-quality patient experience is making sure that the patient actually gets better and that they feel confident that they are going to get better. We think that that actually provides about 75% of the core aspects of a good patient experience. Because of that, we focus on three major things within ensuring that quality care. We make sure we hire the right providers, the right healthcare providers. We make sure that their environment of care is terrific, so they have all the drugs they need, the labs are always working, the machines are always working, they have real access to the tools that they need to provide quality care. And then we have a quality assurance program where at the end of each month, we look at charts. We actually do a chart review, and we review to make sure that the care that's being provided to our patients is meeting evidence-based standards that have been developed around the world. I want to transition now, and I'm, of course, happy to talk with any of you in the future about Penda's model, or if there's anything that I can help flesh out or kind of give you a better picture of. But for now, I want to just move on to talking about the real impact that being a part of this collaborative had on Penda. And I think that Tricia said it well when she said that a lot of what was wonderful and beneficial about the collaborative was just getting to meet other people who are doing the same thing that we're doing. And what that meant for Penda was that we got to go and we got to see the other facilities that Ross had and really learn from them about what their facilities encompassed. We got to see their space, how they did their construction, meet their providers, meet their front office staff. And that really helped Penda understand what would be possible for Penda to add to our services. 4 months after visiting Ross clinics, we actually added dental care. And we added dental care. Prior to visiting Ross, we had very lightly thought about it. But after visiting Ross and really hearing from them about exactly how they rolled it out, what the service level they had was, how did they hire the staff for it, how do people pay, we rolled out it's almost like we have a branch of Ross within our clinics. We really took everything from Dr. Devashish that we could and really were able to kind of share and learn from each other. And we rolled it out. And it's actually the most profitable aspect of our business model today. It was an enormous learning. It really helped our sustainability, and it's made our patients incredibly happy. And the thing that I think is really unique is that when you're getting advice from someone from another country who's as passionate about primary care as you are, there's no competition in the room and there's no agenda. You're just sharing as people who are passionate about primary care. And I think that's why it was particularly had an accelerating effect on the speed at which we could open that service. The second thing I just wanted to mention as a real learning that we walked away from the collaborative with was that we had been spending a lot of time thinking about how to provide quality care at Penda, but we didn't really know how to affect change. We knew that we could track quality care. We knew that we could look at these different indicators of quality, but we didn't know how to effectively make our providers buy in to changing their behaviors. And LifeNet is a terrific organization from Burundi. I'm sorry they couldn't be on the call today. They do a lot of quality change in Burundi. And what they shared with me was that they show the scorecards of different organizations to each other, anonymized. They can't see whose scorecard it is. But through doing that, it provides a benchmark. And so then the providers want to sort of compete with each other to try to push each provider's numbers higher. And so we implemented this strategy, and we went from 35% compliance to 79% compliance in 5 months. Prior to that, we had achieved from 20% to 35% compliance. So we had achieved 15% change in about 9 months. And then we were able to achieve 40% change within 5 months. So that was really, really meaningful. And again, you know, the depth through which LifeNet took me through how their processes worked was just a really unique opportunity. It wasn't you know, just a casual conversation. We were really looking at spreadsheets together and using real examples. So that was just really, really a wonderful experience for us. And I think, again, only facilitated by the trusting relationships we were able to build through the collaborative. I just want to leave you with two little pieces of advice, and this is kind of, you know, simulating the collaborative now, and I hope that these two things will be helpful to you, to all of you here. But I can't emphasize enough how much putting our patients in the center and designing specifically around what they wanted and what they told us that they wanted has helped Penda accelerate its growth. People always say, well, how do you know what your patients want? How do you put them in the center? What do you mean you have them in the center? How do you achieve that? And I just have to say it's as simple as asking them. You know, just set up focus groups, do surveys. When we want to know if we should roll something out, we just go and we walk around on the streets and we just ask people, 10 or 15 people, you know, do you think this is a good idea? How do you feel about this? Or we have a day where we'll give tea to patients and we'll ask them to come in and they'll answer little surveys for us. Patients want to participate in the design of their healthcare. So just ask them and design for them. And then my final tip is that your patient numbers are so important. You will celebrate the number of patients that you've seen and feel excited when you go from seeing 100 patients a month to 300 patients a month. But don't be tricked by marketing. Marketing can always help you grow your patient numbers, but what matters the most is actually the number of patients who are returning to you. So look at how many patients you have and then how many of those patients have come back. Don't just look at the growth of your numbers. Look at how many of your patients are coming back, and that will really kind of tie you in to the previous idea of that that your the putting the patients in the center. You know, when you put them in the center, that's when you're really going to achieve this great return rate. So it's kind of those two ideas are really linked together. I think that's all for me. I think I get to hand over to Dr. Devashish now, and he gets to share quite a bit about Ross Clinics as well.
All right. Thank you so much, Stephanie, for that wonderful presentation. I would like now to, before we go to Dr. Devashish, I would like to circle back to the poll which was done a while ago. I would just like to show you that most of us here in this meeting room said that the key challenge from the all 10 questions posted is how do you continuously improve your model? This is the greatest challenge that most of the attendees here experience when Tricia asked the question, which of the following do you consider as a key challenge? So thanks, and I hope that you're now seeing the poll results. I'm now giving the floor to Dr. Devashish for his session. Dr. Devashish, are you now on mute?
Yes, hi.
Good. Take it away, sir.
All right. Very glad to be here and very glad to hear from Tricia and Stephanie. Again, yes, brings a lot of memories back of working together for that year. It was really, really fortunate that we got that chance. So quickly about us, let me spend a few minutes on just explaining our model. We are focusing on reviving the tradition of the family doctor, the doctor that used to be there earlier, who the whole of the family would go to, have a long-term relationship. The doctor would know the whole family, and the family would also have that trust and warmth and just that good relationship, long-term relationship with one single doctor. Somehow in the age of corporate healthcare and the specialization of healthcare, that system, that tradition has been eroding. And we are working to revive that because we believe very strongly, we are passionate about this, that the family doctor has to be at the center of the healthcare system. So we are building long-term relationships based on trust, and the major way we do that is by sharing information. We listen to our patients and we share information with them, and pretty much that's our one thing that builds the trust. So we are a chain of primary care clinics in Gurgaon with a focus on middle-income families, and our basic service model is similar to Penda's. We also do a lot of home visits and provide a lot of health services to corporates. So we do health checkup camps, we do health talks, vaccinations, and that also helps bring some additional revenue. So we have 4 full clinics and 6 satellite centers in Delhi NCR. In 2014, we served 20,000 lives. We started in 2011, and we have gradually grown to these numbers. Our differentiators are 4, as I can summarize. One is the lean model. We keep our space very lean. It's about 300 to 600 square feet area. In terms of people, the typical clinic is only 1 doctor, 1 dentist, and 1 assistant. And our products and services are also very lean. Just whatever a typical Indian family needs on a day-to-day basis, we provide all of that, but nothing else. We don't go specialized. We don't admit patients overnight. We try to focus our efforts, our model on basic primary care. That being said, providing basic primary care is not simple. We have to have a diverse service platter, and whatever mild to moderate service, illnesses patients walk in with, we are able to provide quality care for that. We have to gear up for that. And having a diverse service platter also means that from one clinic to another, there could be different services that take up a primary role. So in some of the clinics, for some reason, people get injured a lot at that clinic. So we do a lot of tetanus shots and wound care and rabies shots after dog bites. And in some other clinics, there are more of children coming in, so we do a lot of vaccination of children. So having a diverse service platter really helps hone into the primary needs of any community that's surrounding any clinic. Empowering people has to be an integral part of this, and we believe very strongly in that. We have made sure that our providers, the primary care doctors, they are empowered to take care of all the day-to-day care that a family needs, and they are trained to do that, they're encouraged to do that, and they're given independence to how to practice that. Same ways, our middle management is empowered to take decisions. Our clinic managers and their assistants are empowered to learn more and take everything to the next level. We also, I think, believe that our technology reliance has been part of our success. We believe in simple tools, though, as simple as email and as simple as Google Sheets, Google presentations. So we need technology to keep track of whatever is going on in our different clinics and different sites, but simple tools sometimes suffice. As simple as a patient ID, giving a patient ID to each patient, just as simple as that can help us keep track of who's returning when. And as I said, Google Sheets can help us track our inventory in a much better way. So our current focus is on standardization of our services, the backend, and going more from urgent care to chronic care. And in future years, we want to continue to collaborate in various different ways and to expand contiguously. Our goal is 100 clinics in 2016. So keeping our fingers crossed for that. So this is the collaborative visiting our Ross clinic in Sector 49 Gurgaon. From the collaborative, quickly the lessons that we were able to take away. Setting SMART goals for the organization was helpful, even though it changed midway, and we thought whatever we thought we would be able to do, we were not able to do that. But it helped in a lot of ways to align the operations to the vision and mission. So vision and mission are feel-good, buoy statements, and day-to-day operations generally don't bear a lot of resemblance to that. But whenever we had meetings with middle management, we were able to say, okay, this is our goal for this 1 year, and that's linked to the vision and mission. But that's our short-term goal for the next 6 months or 1 year, and let's align our operations to that. And for the purpose of, for the duration of this collaborative, we were able to reach our goal of being loss-making to profitable as a whole, an organization as a whole, through cost cutting and through efficiently organizing our backend, and through adding more revenue streams. Another thing that we took away from this collaborative was to quickly innovate and do this in quick innovation cycles. There are tools to do that, where you study and then you implement and then you study again and then you make changes to that and then you replicate for the organization. We did that with a lot of different ideas. One of the simplest ideas was the Ross Mile card. So the problem was the people came in asking for discounts. And initially, we were not giving discounts on medicines, but all the pharmacies nearby were giving a little bit of 10% discounts on the medicines. So these people would walk over to the nearest pharmacy. So we said, okay, we'll make this an official thing. Everyone gets a Ross Mile card, and once you have a Ross Mile card, you get a 10% discount. And yes, people then started leaving their Ross clinics with a smile. We took up the learning of follow-up calls from Penda. We have been implementing it in one of our clinics, and it has been really, really good in terms of understanding where we have done right thing and which of the patients still need more care, as well as just patients feel awesome when someone calls and asks them, okay, how are you doing today? So we will be continuing to work on this innovation in the near future. Whenever there is new medicine added to our formulary, we try to follow the same quick innovation cycle to make sure that we are doing the right thing and not just going by, touch freely and say that yes, we may start this new medicine. Yes, listening to the customer has been a very, very big learning, and again, Penda, Stephanie is the expert on that, and we've been all learning from her. Focus groups, calls, whatever ways and means you want to adopt, but you have to learn to listen to the customer. And sometimes listening to staff can help also. The staff is interacting with the patients on a day-to-day basis. As an owner or as a doctor, the patients may not tell me a lot of things, but when they interact with the staff or the managers, they may tell a lot of other things that are bothering them, and we can correct those. Of course, being a part of an international network has its own prestige, and I'm loving all the attention. And I think Tricia pointed out that similar innovations in diverse settings, that's just so much of a powerful boost to the morale that what we are doing is worth the while, and everyone else is doing it in different settings, and that's just being very, very very lifting. It can be very lifting. So I'll just spend 2 to 3 more minutes on the insights from the journey so far, and some of this is in the handbook, and you can go through that. So I'll just quickly skim through these. So we have to start quickly and keep innovating. We could do a lot of background surveys, but from my personal experience, learning from the community through surveys has utility only to a certain level. After that, you just have to start, and once you start getting paying customers, those are the feedback. That's the feedback that you need to know whether you're doing the right thing, and what all you need to do to continue to get those paying customers back to you. Other learnings are that the reasons to innovate is that each community is unique. Every clinic is located in a very unique community, and we have to innovate to keep on serving that community. And for that, quick innovation cycles help a lot. It's very important to keep the model lean, especially in primary care, because the growth is slow. With whatever we do, the growth is still slow, and it's very important in the initial days to keep the model lean, to keep our costs low. So we have to figure out our core services and products and stick to them, and not be swayed by, okay, these swanky services we can start. At the same time, it's important to be frugal, but not to cut corners. Exploring additional revenue streams makes sense, so long as we can deliver those services with the same kind of staff and setup. So we can look at fixed fees, we can look at retainerships, we can look at premium services such as home calls that the same staff and doctors and the clinic can deliver. At the same time, it's very, very important in a primary care organization to keep the focus on people, to train them, to encourage them, to supervise them, and to grow them as individuals. And that's what builds the culture of respect, mutual trust, and a culture of transparency as well. Once we have the mutual trust and respect, that everyone is exposed to whatever the organization as a whole is going through. Very important to focus on operations because as the primary care organizations, we end up doing 1,000 things, and each one of them needs to be looked at on a continuous basis, repeatedly. So details are very important, and in that, technology can help. Will you reports and compare things from one time to another? That technology can help a lot in that. And share the dream with everyone. You are the one who's going to be the most passionate about your idea, and the more you share the dream with everyone you meet, the more you spread the energy around, and the more you get this ball rolling. And that's how I make friends. Just go out of the way to help people, share critical information that may help them. And I think with each patient, we have to ask ourselves, what would I do with this my brother, sister, or parent or child? We would go out of the way to help our relatives and parents and children, and that's what we have to do for each patient who walks in. And once we have made friends, this way we can exploit our network. But to exploit the network that we already built, we got our logo design from one of our school classmates, and I still have to take him out to lunch for this. But all kinds of bootstrapping, all kinds of diversity is okay, as long as you are within the law, I guess. But ask for help whenever you feel like floundering or things are not happening as you think. It's a roller coaster ride. You need to have lots of patience and just enjoy the ride. So that's all I have to say. We can download the Innovator's Handbook at this link that is there on the last slide, and our email addresses are also on the right slide in case you, after the session, you want to get in touch with us. Hand it over to Alia.
All right, thank you very much for that very comprehensive session. That was wonderful. And we still have 2 more minutes to answer the questions that were posted by our audience. I hope, for those which we will not be able to address, we will be emailing it to our speakers, and then we will get back to you for their answers. Just don't forget to visit your email so that we could send all the answers to your questions. Let's get a question from Alex Najobi. I hope that I got it correctly. The question is, who makes the follow-up calls to the patients, assuming it's the doctor or nurse? How do we persuade them to fix it into their busy schedule? It's a nice idea, by the way. Can you answer this, Tricia?
Yeah, though actually I'd love to turn that over to Steph from Penda, since many of the learnings that our members got around putting patients front and center really stem from Penda.
Thank you very much. For another question from, this is from Vince Tobias from the Philippines. This is directed to Stephanie. Your experience is very inspiring. How do we get in touch with your collaborative so we can apply your business models in the Philippines? Stephanie?
Yeah, and actually, Steph, maybe you could also answer the first around who exactly does the follow-up.
Sure, wonderful. Well, interestingly, I'm going to pass the second one back to Tricia. Certainly, go online and register at on the CHMI website. I think that that's a great way to get involved and kind of interact with other collaborators, but also get in touch directly with me. I would love to do a phone call and see how I can help. I love to sort of share and talk with other people. So I'd be more than happy to do a phone call. Just email me and I'll set that up. And then as far as the follow-up calls, I think the key thing is convincing your doctors and nurses or whoever your providers are that doing this follow-up call is not something extra. It's actually core to patient care. So you have to convince them that it's just as important to do the follow-up call as it is to do the lab tests, to give the medicines, to ask the history. And so that's really what Penda spent a lot of time doing, is showing that we could actually get better patient outcomes when we did these follow-up calls. And it was just anecdotal. I mean, we just really went for it with passion rather than specific research, although we would love to do that research one day. But the doctors themselves do each and every single follow-up. And one thing that does in addition, which is very nice, and Dr. Devashish can probably comment on this more, but providers are very motivated by patient feedback, and they really like to hear feedback from the patients themselves. And when they make the follow-up call themselves, they get to hear a lot of positive affirmation about their treatment plans, and that's really inspiring and motivating.
That's correct. That's so correct. As a practicing physician myself, I can attest to that. It feels so good to hear, oh, doctor, I am just calling you to let you know that I'm feeling better. And of course, the other way around also. I mean, we can be, if a certain drug, certain antibiotic is not working in certain season, then we can get on top of it and change our primary antibiotic. And we have done that in the past, just based on the feedback calls.
Okay, perfect. And last question. For the other questions, we will just email it to our speaker so that we could address everything comprehensively. Last question from Prabeen Raj Shakya from Nepal. What are the challenges in microinsurance in our In our institute in Nepal, we first introduced the microfinance and then we introduced microinsurance, but we had a challenge to motivate people to join microinsurance.
I don't know, is that okay, sorry, yeah, of course, no. Well, we actually don't do a microinsurance model ourselves. So we are a provider which accepts many microinsurance cards. And exactly as you said, I mean, the uptake has been very slow. It's not been ideal. I think a lot of the products, the microinsurance products, are not being designed with the patients in mind. I can point you at resources to get more information on that and maybe connect you to some of the microinsurance providers here in Kenya. One of our clinic managers actually has a background in microinsurance, so I'd be happy to set up a call between you and him. But I personally can't speak to that very well.
And just to circle back with that. Oh, thank you. So this organization was part of the primary care network itself, but I worked with LifeSpring Hospitals, which is a maternity hospital based in Hyderabad. And I bring them up because we actually talked a lot about microinsurance and also financing, particularly to finance births and deliveries. And I know one of the challenges that we faced early on was how exactly to do that. We had thought about it in terms of actually starting not necessarily a microinsurance plan, but a financing arm within LifeSpring. And as you can imagine, one of the challenges is that it's a very different skill set and operational set than actually providing the care. And so then the next step was really kind of partnering with other MFIs, which it sounds like is something that you've started to look into as well. But I think that, that was one of the learnings, at least for LifeSpring, was the need to really separate that from operations. And then I did just lastly want to circle back to the second question around how organizations and really all of the practitioners on this call can get involved. Really the first step is just being part of the conversation. And so you could do that a number of different ways. One, of course, is downloading the Innovator's Handbook, which is on the CHMI website. And we hopefully will be having more of these webinars and interactive blogs. So we have a blog series that also allows participants to really share their own learnings and what's working. And then within R4D and CHMI, we're actively thinking about how best to really take this forward. And so if you sign up to be on the listserv, we of course will keep you posted, and would also love to hear kind of how this handbook has worked for you and things that we can do in sort of a version 2.0.
All right, Tricia, thank you very much for the very comprehensive question. We have 3 more questions, but I think we don't have more time to address them in this session. I will send all the questions to our speakers for this evening, and I hope that they will try their best to answer that more comprehensively, and I will be emailing all the feedback from our speakers to all of the attendees in this meeting room. And maybe we could schedule another call for just a discussion on the topic for this evening. So that's it. Thank you very much for being with us this evening. Again, I am Aliyah Evangelista from the Asia eHealth Information Network. I would like to invite you for our next webinar on April 30, and that's 3 decades of eHealth at the Hong Kong Hospital Authority, to be delivered by CP Wong. It's going to be 16-hour UTC GMT +8 or 4 p.m. Manila time. Thank you, Devashish. Thank you, Stephanie and Tricia and the R4D for your very kind time for this webinar. See you, everyone, and please visit your emails for feedback. Thank you.
Thank you.
Everyone.